Firstly, Ayubowan, thank you for inviting me, Adeva, and the College of Psychiatrists. I'm really honored to be speaking. I was born in Sri Lanka, in Colombo, but my family moved to Australia in the 1970s when I was a year old. So I studied in Australia and trained in Australia and the US. But my uncles, Jagat Vijayasekara and Gamini Vijayasekara, were doctors in Sri Lanka, so we still have a lot of ties with the country and very proud to be speaking. As mentioned, my work in Australia, in Newcastle, is to do with, we have a large service that treats addiction, mainly in tertiary hospital facilities and withdrawal units, but also we have opiate dependence substitution services and have some research as well that we're doing. My interest, there's a lot of interesting things that I'm part of. We're doing a trial looking at TMS, transcranial magnetic stimulation for methamphetamine use disorder. Also, there's a lot of new developments in terms of habit formation, salience, and the neurocircuitry of dependence. And today, though, I'm really excited to share what I know about intervention for substance use disorders that is 40 years old. As a public health specialist as well, I think that sometimes simple things have a value and are worth reminding ourselves of that. So today, the talk is to cover in 20 minutes what we know about motivational interviewing and really a refresher. My apologies if I'm sure this is a modality that is already part of your practice, but I wanted to summarize some themes and concepts that might be of interest. So the reason for me that it's an interesting area is that while in addition to the pharmacologic and other psychotherapies that have been part of my practice for dependence and treatment, this is a very simple modality that in meta-analyses have similar effect sizes to, a lot of common pharmacotherapies that we use. It's relatively simple. Within 2 sessions, you can change someone's habits and see benefits in terms of substance use decreases. And so, and it's something that with Deva and others, not only in Australia, but in Aboriginal communities where I work and also in international context, there's evidence of its effectiveness and utility. So today I won't have time to go into a lot of the details of the specific application of it, but maybe the hope was to give you some background of why it's something that I think still has a lot of value in the substance use area, and also in terms of habit and health behavior change, given that a lot of our work requires the cooperation of patients. It was developed in the 1980s and really draws on a work that I think has been much older than this, Carl Rogers and others, the client-centered approach. And one of the things that got me interested in looking more closely at motivational interviewing was a talk that I heard by William Miller, who was one of the developers of it in the 80s. And he was speaking about his early work in the 1980s in Milwaukee in an alcohol substance use service, where his research was finding that for patients who presented with alcohol use disorder, the outpatient counselors and therapists that were working with clients, or when they averaged the outcome results in terms of self-reported substance use, their outcomes were in some cases similar or no better than if the patients were given an alcohol, how to quit alcohol pamphlet. And he was surprised by these findings, repeated the study several times, and actually when he disaggregated the results, found that some of the people that were engaging with patients actually had a worse outcome than if the patient was given a simple information on how to quit drinking or reduce the alcohol use. And so in studying that, I think this was the genesis of motivational interviewing. And this simple study that he did, which has been replicated, I think draws out some of the themes that I'll talk about today. So in the study, people were given 10 weeks of either weekly counselling sessions or of a pamphlet, and they were reviewed at the end of the 10 weeks and subsequent follow-up to see whether their self-reported substance use was the same or different. And what was interesting was they evaluated the style, the counselling style of the therapists, and specifically for a validated score of empathy and how well the therapists were developing empathic relationship with the clients versus a directive one. And what they found was they ranked these the 9 therapists who were working with clients, and 1 to 9 on against the positive outcomes at 6 months in terms of substance use. And the red bar is if people were just given an information brochure. And what they saw was there was a certain group of therapists on the left who had much better outcomes than if patients were just given an information brochure, and then some who did much poorly. And in understanding that, this score of empathy in the therapist was correlated quite closely with how the clients did, and where the therapist on the left side, the empathic style where they were guiding, collaborating, encouraging patients, versus the directive style of telling people what to do to stop drinking, actually produced the worst outcome than if that people were just given information. So this, in terms of the effect of this, the correlation persisted in terms of the better outcomes with the empathic style over 6 months, 12 months, and 24 months follow-up. And the variance in the difference between patients, up to 70% of the variance at 6 months could be explained by the style of the therapist. And that was 30, 40 years ago what formed the basis of sort of this work that now is a very commonplace in my practice and my service of all clinicians and people that we are part of our service and working with clients have some background in this. So motivational interviewing builds on the work of Carl Rogers and the client-centered approach, and it really has been confirmed in decades of work that in different forms of therapy, psychotherapy, ultimately the empathy, warmth, and therapeutic relationship is closely correlated and predictor of outcomes, sometimes independent of that specific intervention. There have been meta-analyses of motivational interviewing. Given the years that it's been around, it's the last one large one was in 2005, but subsequently there's been meta-analyses of programs in more specific populations like adolescents and alcohol use, or in international settings. And just to summarize, one of the ones that has brought together 72 clinical trials, and to briefly mention it, we see effect sizes on average of 0.3 to up to 0.7 for the not only alcohol and substance use programs where people sometimes receive 2 sessions of motivational interviewing, but also for other behaviour change where there's the client's behaviour is important for the outcome. So just to summarise briefly what motivational interviewing is, it's a directive, client-centred form of counselling. It enhances motivation for behaviour change by exploring and resolving ambivalence in the client. it increases commitment and conviction and confidence in change. And at the core of it is empathic style of listening that minimizes resistance. And I'd like to just talk a little bit about that. So this is the Da Clemente and Prochaska model of stages of change, which, while not necessarily always helpful to direct the specific treatment that a patient might need at a certain stage of change, is helpful as a conceptual model to understand where someone is and to tailor an intervention to that. In the pre-contemplative stage, they do not see there's a problem. But in the contemplation and preparation stage, that's where there's ambivalence and there's the problems of the substance use have been identified, or the harmful habitual behavior, but there's also a debate whether or not there's also perceived benefits. And so resolving that ambivalence can be helpful towards progressing the patient to a more action stage of change. And in my practice, I mean, we see a lot of professionals. Every behavior often, when it's in these early stages, is associated with some perceived benefits. So whether it's drinking alcohol with peers and a social side, or as a way of a perceived way to relax. In terms of the specifics around resolving ambivalence, one of the reasons why the directive style of telling someone to stop and what they should do in many contexts, and in the research shows that it has worse outcomes than doing nothing in some cases, is that unlike diabetes or an illness where the client is coming to get technical advice on what they need to do to improve, if it's specifically, if they require a medication or something like that. With a habit, the client often is aware of the benefits and the harms of what they're doing, but there's ambivalence. And if they encounter a clinician who wants to help and sees their role as telling the patient what to do, that ambivalence results in the clinician taking from the client the reasons to change in the conversation, and then it leaves the clients with the reasons not to change. And often they can end up with a tension where the clinician is arguing for something, the client then, ambivalent client, takes the positions of why they change is hard, and you get this contest of ideas. Now, the way to resolve that is what motivational interviewing focuses on. And it depends on the clinician's level of request or demand for change from the client. The higher that is in the clinician, the studies, and this one that I've quoted in 2009 is one of them, the higher that the level of demand for change or request for change from the clinician, it crowds out potentially the motivation in the client. And when the clinician is able to provide empathy and guide the client, then it increases the change talk and the opportunity and the motivation in the client. So two ingredients are important. One is the therapeutic relationship, and I mentioned in a previous slide that this is something that is common to many modalities. And then the specifics of motivation interviewing is how to have a conversation where you get the client to give the reasons for change rather than the clinician. We know also from some of this work that Miller and others have done is that as motivational interviewing, what it can do is increase the change talk that the client has. And we know that the change talk, the reasons to change, the benefits of change, the mechanisms and how to change, when you start hearing that in a conversation, it increases the client's motivation and it increases the client's probability of change. Additionally, if during a conversation you start to hear more resistance, the reasons why it's hard to change, then We know that leads to a reduced probability of behavior change in a client. So motivational interviewing, what it tries to do is decrease resistance while increasing change talk. What do I mean by change talk? So it's basically the words and statements during a consultation that have the action steps to and speak to the values and needs that a client might have in terms of the benefits of quitting or of a positive behavior. For example, I really need to quit drinking because it's a bad example for my children, whereas the sustained talk might be but it's the only way I know how to relax and socialize. So often the statements that appear after the word but when you're having a consultation with a client are the sustained talk, the reasons not to change, and the words before that, the but, often are the words of the change talk. And enhancing the change talk while reducing resistance is the goal of a conversation informed by motivational interviewing. And again, drawing on that work that Miller did, what we find is a directive style when the consultation is analysed for words that guide us to sustain or change talk. We find that the directive style where the clinician is telling the client what to do or what they should do, we find more resistance, that's the red boxes, and less change talk than compared with an empathic style of engagement on a subject of a habit that a client might want to change. So what that leads to is increasing conviction and increasing confidence over time. And sometimes this can be in as much as 2 or more sessions. On the other hand, reducing confidence, or if there is a opposition and resistance during a conversation about behavior change, we know that it can leave a client frustrated or with less agency and a sense of change, that change is possible. What are the core elements of motivational interviewing? Well, because of the 20 minutes that I have, rather than go into detail about the specifics, what I would like to direct you to is a non-profit organization set up by the founders of motivational interviewing. It's unlike a lot of therapies where there's a proprietary model that's fee for service. This one is quite a decentralized, open way of training, and it's relatively inexpensive. I think the first level course is about $50, and it's also relatively small investment of time, sometimes 1 to 2 days or a couple of hours over a few months, and they can be done online. And I would direct you to that if you're interested in more information specific to this. But while in the few minutes I have left, I'll just summarize what I mean by this empathic style of engaging with a client on a substance use disorder or behavior change strategy. Basically 3 core principles, and then there's a lot of detail that can be added on, but it's essentially expressed empathy. Again, that's the Rogerian model. Asking open-ended questions as opposed to closed-ended questions, and reflective listening. What do I mean by expressing empathy? Listening in a supportive, reflective manner, demonstrating that you understand the client's concerns and feelings, a specific and learnable skill for understanding another's meaning through the use of reflective listening, which I'll talk about later. It requires sharp attention to each new client statement and a continual generation of hypotheses as to the underlying meaning of what is being said, not directly just the words. And the key to expressing empathy is reflective listening, which I'll talk about. An empathic style communicates respect for and acceptance of clients and their feelings. It encourages a non-judgmental collaborative relationship, establishes a safe and open environment for the client that is conducive to examining issues and eliciting personal reasons and methods for change. It allows clinician to be supportive and a knowledgeable consultant. It compliments rather than denigrates, and it listens rather than tells. and gently persuades with an understanding that change is up to the client, and provides support through the recovery process. Now, specifically, these two things that can get in the way. Giving advice in the area of behavior change can, as I said, create passivity and resistance, and from the work that has been done, doesn't actually lead to correlate to behavior change. And that's something hard in the trainings that I run in this area. It's often difficult for especially clinicians who have a desire to help the client to avoid giving advice on behavior change. That's what motivational interviewing and trainings focus on. One of the things around the open-ended questions versus closed questions, and also non-empathic approaches, is that closed questions or directive questions and advice can lead to increase in things like shame and a sense of fear, rather than hope and confidence that change is possible, and ultimately it can be detrimental rather than support a client towards a goal. How are I going for time, Deva?
Buddhi, you have gone 1 minute over time. You may take another 1 minute,
Okay.
if that's okay.
Let me just, yeah, that's fine. So what I'll do is I'll just go to summarize. So in terms of the final point, which is reflective listening, again, there's strategies: simple reflection, which is reflecting back what has been said. Double-sided reflection is listening for words where the client both talks about the reasons for change and sustained talk and reflecting that. Affirming when there's commitment to a change that is being discussed, and summary statements that essentially bring together what's been said. I won't go into the detail because of time, but again, just to remind you of these 3 points, and that if you want to look further into it, there's a lot of resources on this site. It's a not-for-profit and it's easily accessible. Thank you.